And now for the moment that you've all been waiting for, it gives me great pleasure to introduce to you our keynote speaker for this evening, Prof. Alyson McGregor. Alyson is a physician, a researcher, and a writer. She's Associate Professor of Emergency Medicine at the Warren Alpert Medical School of Brown University, and she's also Director for the Division of Sex and Gender in Emergency Medicine. Her research on the roles sex and gender play in emergent conditions has actually made her a spokesperson and advocate for women across the globe. Alyson serves as a member of the Advisory Committee of Research on Women's Health at the Office of Research on Women's Health at the NIH. She's also co-founder of the national organization Sex and Gender Women's Health Collaborative. She also recently served as co-chair on the Sex and Gender Health Education Summit, which is designed to establish an integrative sex and gender curriculum for current and future healthcare professionals. Alyson's TED Talk, Why Medicine Often Has Dangerous Side Effects for Women, currently has 1.6 million views. And she has recently released her new book, Sex Matters, How Male-Centric Medicine Endangers Women's Health and What We Can Do About It, available from Hachette Book Group Publishing. Now, over to you, Alyson, for your talk.
Thank you so much. And I just want to start by thanking NogaFem for not only inviting me to be part of this conference, but to also thank them for creating this platform to be able to spread awareness that these issues regarding gender and how they fit into our technology are really crucial. And so what I hope to bring to the table is the viewpoint of how critical these things are when we think about our healthcare. So as was mentioned, I wear a lot of hats. I do research and I write and I'm an advocate. And that's all on the side of my day job, which is I'm an emergency medicine doctor. And I love being that person because I get to be in a very fast-paced, exciting environment, but also because it's really been a way that I could view the entire spectrum of health and disease. And I started to really look at what I was being taught in medical school and in residency, and how that actually translated to healthcare for the people that I was caring for. And I started to see that there were some gaps, especially for women's health. So, when I think about what I was taught, I'm sure many of you feel that this is a similar model. We were taught that the sperm and egg come together and they decide what sex chromosomes you have, which would decide what sex organs you would have, so ovaries or testes, and then that would be responsible for the sex hormones, estrogen or testosterone, and then they would provide us with our secondary sex characteristics. So our voice change, breast growth, hair growth, that sort of thing. And other than that, we were pretty identical. And that, really is not what I have witnessed and what I have researched, because the truth is men and women are not the same when it comes to health and disease. And I can see this every time I'm in a shift when, 78% of all autoimmune diseases occur in women and not men. When men are more likely to die of sudden cardiac death during exercise, 30 times more likely than women. When heart failure mechanisms, the actual mechanism, pathological framework of heart failure is different between men and women. Women have things like irritable bowel syndrome and migraines that are really poorly understood and therefore poorly treated. And so even when a disease occurs in both men or women, someone has a greater incidence or a greater severity than the other. And why haven't we really embraced this? Why do we need to talk about this now? It really dates back to how human subject research first came to light. And this is a grim photo, and it's meant to be because when you think about how we really started out, we often used enslaved individuals as research subjects. So World War II and the concentration camps. And in the United States, some of the famous trials like the Tuskegee syphilis study. And so there was this real need to create some sort of protection for human subject rights. And there was also at this time, we were discovering that certain drugs, when given to women of reproductive age, if they became pregnant, resulted in birth defects like thalidomide. And so the National Research Act around 1974 in the United States actually said we need to make sure we have informed consent. So we need to make sure that when we are enrolling individuals into human clinical trials, they have an understanding of what the risks and benefits are involved. And so that was very important and established the institutional review boards that we still rely on today. But because of those experiences like thalidomide, what happened was at this time, they also labeled women as protected subjects. So if you were a female of reproductive age, you were considered too risky to study, and you were not allowed to be part of the study. And this was sort of embraced because women have the menstrual cycle and it fluctuates. And so in order to make sure that you take that into account, you may have to increase the number of women that get enrolled to make sure the study is powered. So research was then performed on men and even male animals. And so what's happening is we started really understanding evidence-based medicine and the scientific method at this time. And so our large cardiovascular trials and stroke trials and our understanding of cancer and infections and trauma were all based on studying men. And the only thing we couldn't study in men was breast health and menstruation and menopause and giving birth. And so we studied those things in women. And what happened is it trapped all the efforts into providing medical care for women into only those issues. So by trying to protect women, we did them a great disservice because we thought that men and women were alike enough that we could apply those knowledge from men into women. However, when you look at the differences at the cellular level, it starts with those sex chromosomes. Whether you have been assigned XX if you're a female and XY if you're a male, those sex chromosomes are not just in the ovaries and the testes, they're in every cell in the body. They are in those heart cells that help develop disease in certain ways. Our liver, it's been thought that there's over 1,000 enzymes in the liver that have sexual dimorphism, so act differently whether they're in a male liver or a female liver. Our stomachs have different gastric pHs, and women have slower intestinal transit times and slower gastric emptying times. These things affect our metabolism, especially of medication. And speaking of that, our kidneys, the way that they have excretion of medications. For instance, we now know that acetaminophen, men are more likely to excrete that as a faster rate, up to 22%. Men excrete zolpidem, Ambien, a sleep drug, quicker. They excrete propranolol, a beta blocker, quicker. They excrete benzodiazepine, like a Valium, quicker. And you know what? There's really not sex-specific dosing recommendations based on any of these. And so this is really happening at every cell in our body. Now, when we think about gender, we live in a gendered environment. And culture, society makes an assumption about your gender by the way that you look. Okay, so that actually does impact our health. If we think about women that live in a cultural environment where they wear burqas and they cover up a lot of their skin, that actually has been shown to decrease skin cancer in those women because of the sun exposure. But also they're probably more likely to have vitamin D deficiencies because of that sun exposure. So you can see when you present yourself in society as a particular gender, there are implications for health. And when we think about that with men, I think about my trauma rooms filled with men who, are expected to do the hazardous things in society. And so they're constantly involved in traumatic injuries that do have a great impact. And then let's think about our environment. Who created the desk that I'm sitting at? Who adjusted our world? And did it take into account the differences? And so nowhere has that been shown to be more important than, say, crash test dummies, the way that we use to make sure that manufactured cars are safe. It still does not exist today, a adult female crash test dummy. Okay, so we're still using the male crash test dummies. What has that resulted in? Well, the research has shown that, if you are a woman and you're sitting in the front seat, whether a passenger or a driver, you are 73% more likely to be seriously injured and 17% more likely to be killed. Women sit closer up to the dashboard. We have wider pelvic rims. Men have stronger neck muscles that are able to help with some of the whiplash. These things need to be part of our design of our world because car manufacturers are designing the cars to pass these tests. And if these tests are using a male model, women are going to be left out. And the consequences can be grave. Doctors, we think we're practicing evidence-based medicine. So we're doing our due diligence. We're going to the literature. We're looking it up. But what is our evidence based upon when 76% of cell-based researchers don't know the sex of the cell they're working on? They don't know if that's an XX cell or an XY cell or how that affects their analysis, their outcomes. Animal-based research is still 80% based on male animals. Human clinical trials, yes, we are getting better. We are including women into clinical trials now, but it's not the same. We can't just sprinkle a few women in. We have to design the studies to determine if there are differences in men and women. And that's a separate particular understanding now for excellence in research. Women make up over half the population, and we're the healthcare deciders of the family. How generalizable is this evidence to my patient when I see them in the emergency department? How generalizable is it to us? Because we're all patients at some point. And what has been the consequence of this? We look at one thing. Let's take cardiovascular disease, the number one killer for both men and women. But why is it that women have higher mortality rates than men? They're more likely to have in-hospital mortality. They're less likely to be given evidence-based therapies or be given either diagnosis or testing. It's because we were taught that this is what a heart attack looks like, that it's this man, mostly white, clutching his chest. This is what we were taught in medical school, and it's still being taught, and that's one of the things that we're working on. So what happens is when women present, they may have chest discomfort. In fact, they most often do, but they also have back pain or sweating and diaphoresis, we call it, lightheadedness, dizzy, nausea, unusual fatigue, shortness of breath. So if this is the way that women present, women don't know this. So they're at home still thinking, oh, this can't be a heart attack because this is not what a heart attack looks like. Then when they finally make it to the emergency department or to their doctor's office, they may not be familiar with how women may present with a heart attack. And so this has had lots of consequences. When we were studying men in our major cardiovascular trials, we learned that a heart attack was an obstruction of a large coronary artery, focal obstructive disease. So you have this plaque that builds and then ruptures and creates a clot. And then that is an MI, that's a myocardial infarction, that's a heart attack. There's now no blood supply to that area of the heart. And that's very important. And we've designed our treatments to go into that artery and to open it up. Very anatomical, considerations. But now we know that there's something like microvascular disease, which is a disease of the smaller arteries, the arterioles. And we're finding that this is very common in women because think about this, women have more diffuse body fat distribution. Men tend to have it focal. These things are happening in the blood vessels of the body as well. So it causes irregularities of blood flow. It causes maybe some vasoconstriction or vasospasm. Now, we knew that this was an entity, but when we were studying men, in men, it's only as frequent as 4 to 10% of men may have microvascular disease. But when we translate that to what we know now and looking at women, 40 to 60% of women will have microvascular disease. So what was considered something small and possibly insignificant, when you flip that and you look at that from the women's standpoint, it's quite significant. And so this is what women are hearing. They're hearing that this chronic discomfort that they have is all in their head, that it's probably related to their menstrual cycle, or they have anxiety. Go see a gastroenterologist. You must have reflux disease, or go see this specialist, go see that specialist, right? So this is the messaging that we're giving women. So let's look at this. Let's look at our systemic bias in the healthcare system. When we look at this, say, for instance, if you look at the figure, starting from the left, women are using their iPhones or using wearables, and they're saying, I'm having shortness of breath, or I've been tired lately. It's not registering that this could be a sign of a heart disease. When we look at when they finally do show up, and we look at blood tests, one of the blood tests that we use to look for if you have a heart attack, what we found was that reference range was dependent upon men. And when we changed that reference range, we were discovering we were including many more women that we now realize were actually having heart disease. When we send them for stress tests, there's different sensitivities and specificities depending on whether you're a male or a female. When we're looking at the anatomical ways of disease progression, when we are looking in our electronic health records, when I see a female with chest pain, there's a male figure that comes up, or if I see a male figure for an abdomen, if someone comes in with stomach pain. These things are systemically ingrained into our biases that are allowing these gaps in understanding of healthcare for women to perpetuate. So who is responsible for a lot of these technologies? Who's creating these artificial intelligence that's now becoming really advanced? This is a great paper that actually discusses the fact that we need to make sure that as we advance in this area, that we are including diverse populations. So that means both men and women, but also diverse populations across the country. It's most of these are being tested on a convenient sample, and that's often the convenience of men, because who's around in the office in STEM fields, right? Who's creating this these underpinnings of this technology? We rely a lot on personal health apps, right? So our phones and the wearables tell us when we should eat, or maybe there's certain side effects of drugs, or maybe we should exercise, or when should we go see the doctor. We have this assumption that that's going to be accurate, that it's taking into account who is utilizing this. But what we've actually discovered is that this study looked at smartphones, and they looked at 4 smartphones from Google, Microsoft, Apple, and one other one. The 4, if you think Android, the 4 of the top ones. And what they do is they asked it questions relating to physical health. So they asked Siri, or whoever the artificial intelligence response person is, I'm having chest pain. I'm having a headache. And they all were very good at saying, maybe you should call your doctor. Would you like me to set the phone number? Here's the local emergency department phone number. They were very well established to help assist with that. But when they went to mental health, or interpersonal violence, which affects many women, they did horrible. So they asked, the phone questions like, I'm depressed and I'm thinking of committing suicide. I've been just abused by my boyfriend or my husband. I've been raped. And these technologies had no response. They didn't know, they weren't coded to take into account things that were outside of being, an average white male, unfortunately. So when we think about these things, we think about, well, let's get diversity in the workforce, right? So these things also will help us trickle this into our health products. This group looked at 1.5 million research papers. And when the primary author or the senior author were women, they were more likely to look at gender and specific analysis, because women think of women and we think of diverse populations, think of themselves. And this translates into our research and understanding. This was just published that are saying, what about our clinical trials? We need to have the leadership of those in clinical trials also be diverse, because if you are trying to enroll someone in a clinical trial, you are more likely to identify with someone that looks like you. They're more likely to identify someone that looks like them. So we need diversity in this leadership, so there's trust, and that these people are more likely to be enrolled. Same thing with physicians. There's been a few papers out recently that talk about the gender of the physician and the gender of the patient, and does that matter? And we're discovering in many ways that it actually does. This particular paper looked at the probability of survival. And if you look at this graph, when the patient was a female and then had a male physician, their survival went down significantly more than if they had a female physician. And we're not saying that female physicians are better than men. There has been research that has said women are more likely to use hospital-based guidelines and things of that nature. But also, its diversity is key, because the men that worked alongside women colleagues also did better at caring for women patients. So I think, there's lots of this involved in systemic issues. We all also carry our individual bias. I was, after medical school and learning all of the book work and spending all of this time, residency, our training period is on-the-job training. And we are taught pattern recognition. What does a heart attack look like? What does a stroke look like? And many of these pattern recognitions were based on the research done on men, and also my mentors and what they learned, which was research performed on men. So I think that this is also something that we have to check in with ourselves that can be very important, especially as our understanding of non-binary becomes very important, and our understanding of discordance between biological sex and gender identity. This population is increasing, and we really need to know how to include them into our technology, how to include them into our medicine and health. For instance, this particular paper was just published, and it really shows how important it is to do research based on biological sex and then research based on gender identity separately, so that we can individualize that for the particular patient. This showed that if you have a transgender individual on confirming hormones, then if they took those hormones for 6 months or more, then their metabolism of drugs switched to the gender that they are transitioning into. So this right here tells you that the biologic mechanisms of the pharmacokinetics and the pharmacodynamics of drug metabolism very much is related to whether you have estrogen or testosterone around. And so it's this type of research that's going to help us understand and individualize for people. So when we are conducting research, when you are looking at what technology that you want to design next, you look at what's been done. That's what we do when you create some sort of proposal. But look at that literature review, look at those, the things that are already done, and understand where they're coming from. What did they include when they decided to create that study? How is that generalizable to what you want to do? Everybody needs funding, right? So if you are in some sort of ability to manage funds, make sure that these types of diversity and inclusion are part of the proposal before you accept funding. If you are on an institutional review committee, make sure that both men and women are in the study and that it's designed to look for differences if differences are there. Journal editors are considered gatekeepers of science. And so make sure that you don't even accept a paper if they don't have these issues that we now know are important for reproducibility of our research. Many of us are peer reviewers. Make sure that you include this in your peer review. review, because this is then the information that's going to get disseminated, and then the cycle begins again. So it's this inclusivity. For those of you in science, the Sager guidelines were based out of the International Committee of Medical Journal Editors. They have checklists for editors, peer reviewers, and authors to make sure that you have designed your study to determine whether their sex differences are there. These are very, very good, and they should be part of the process. Lastly, the BMJ, I think they did it correctly. They just came out with this, and this just talks about the both sides of the coin. Who are the subjects and who are doing the research? And what they said was they wanted the editorial board to be 50-50 men and women. They want to make sure that they have equal numbers of men and women as peer reviewers, that when they're asking for editorials, they're looking to make sure that that's equitable. When they want to make sure that they're accepting papers where women are also front and center as the authors. They want to fix biased recruitment processes, even in their own company. They want to make sure that when they have awards, that these are balanced. They want to make sure there are no manels where it's a panel of just men. And it's part of the annual review performances, and can constantly review to make sure that you are updating, because it's this type of influence that can change scholarly publishing and how that translates into our healthcare system. So thank you. I know I sort of went through that fast, but I want to make sure the other panelists have a chance to give their talk, I will come back for the Q&A session at the end. Please reach out to me on Twitter, McGregor MD, also Instagram, and I look forward to our discussion. Thank you.